invitation. I would like to thank especially Veronica and Irina. Coordinating this event so well and so many people is really difficult. My admiration to you. And thank you, Roberto, for your wonderful presentation. This is the second time that we share the screen or the scene. I'm so happy for it. Thank you very much. So let's go to the heart of the lecture. My name is Luca Lavorgna. I live in Italy, and I'm a periodontist who loves the digital workflow. Aesthetic guide dentistry is the core of my lecture, and I would like to show you how the digital smile system also plays an important role in periodontology. But before talking about digital dentistry, we must remember the importance of another tool that distinguishes us in such dentists, the diagnosis. We must always start from that. Always the diagnosis. As Roberto said, just one diagnosis, the correct one. Especially when facing with cases like this. In this case, before starting therapy, I think that we can improve the harmony of the smile by contouring all the elements of the upper arch. We must ask ourselves several questions that we will face together in the course of the lecture. First of all, we must understand what is the cause of this imperfection. There is a reason that does not concern the teeth, but the upper lip with its hypermobility. Or we can have a skeletal disharmony that requires orthodontic treatment. Or we may have a condition that we call active altered eruption, which we distinguish from the altered passive eruption. Understanding which of these conditions affects our patient is essential to implement the correct therapy. Let's quickly look at the important role that the upper lip has. Already 10 years ago, a technique was introduced that's allowed to reposition the upper lip, where the cause of the problem is not represented by the excess gum showing the smile, but is the mobility of the lip. So that's where we have to turn our attention. But how can we identify it? Always observing our patient carefully. On the first visit, we have a unique opportunity to correctly collect all patients' clinical data. And if we observe a discrepancy in gingival exposure of at least 8 millimeters or more between the rest position and the maximum smile, hypermobility is probably the problem. But if the dental elements have a correct proportion, and we understand it by researching and identifying the enamel cement junction, you have no more doubts. The therapy must involve the upper lips and not the teeth. Then we will practice our surgical techniques that will allow you to move the upper lip coronally, as in this way, and therefore to reduce the amount of gingival exposure. Here I share a small historical mention. Who am I talking about? Norma Jane Mortensen. Probably, unless you are a fan, this name won't tell you anything. This lady had a moderate problem, was certainly not as extreme as the previous one, but showed an asymmetrical exposure of the smile, mainly on the left side. The dental proportions were absolutely correct. Do you recognize it now? It's Marilyn Monroe. She had a problem of hypermobility of the upper lip, but was not treated surgically. She practiced it so that the lip didn't move excessively. And in the photographs, she assumed this pose that we all know, so as not to expose a greater share of soft tissue. Bye-bye, Marilyn. Now, let's analyze the skeletal disharmonies. In cases like this, tools like this, the digital smile can help a lot because they can show the patient the absolute uselessness of a procedure aimed at dental or periodontal tissues. Here, a maxillofacial surgical treatment is needed. And here too, it's important to immediately identify the nature of the problem and to communicate it to the patient. Now analyze the protagonists of our daily clinical activity, the teeth and the periodontium. Talking about the condition of this harmony of the smile, we must speak of alteration of the eruption, altered eruption. And we must make a first distinction. We have an active alteration of the eruption and a passive alteration of the eruptive mechanism. Both conditions present pathological alteration of physiological phenomena. It's always necessary to know physiology first so that the pathology can be recognized and treated properly. Well, we have to distinguish the active eruption from the passive one. I will brief in the definitions. The active one is the movement of the teeth in the direction of the occlusal plane, carrying periodontal tissues. In other words, it's the movement that takes place physiologically until the adolescent phase or until each element meets a dental contact. At the moment the active eruption ends, begins the passive eruption. That is the movement of the gingival apically or away from to the level of the CEJ. Therefore, the teeth remain still while the periodontium apicalizes. More precisely, soft tissue move apically because the hard periodontal tissues, the bone, genetically position themselves, if there are no alteration, in the right position. So we have an alternation of active eruption and passive eruption, an alternation that until adolescence sees the active eruption as the protagonist with the physiological breaks, and then actively resume, for example, to compensate the vertical growth of the maxilla. And then the passive eruption that reaches a sort of balance around 18, 20 years old, even if we know very well how the growth of the lower third of the face often continues up to 30. So be careful, colleagues, be careful to place implants in young people in the frontal area. Well, after talking about the physiological mechanism of dental eruption, let's see how to deal with the alteration of that mechanism. And therefore, we will turn our attention to cases like this, in which we have to analyze in detail teeth and periodontium. Why are the parables of the two central unleveled? Is the way of the incisal edge of the right central influential? Always we have to observe our patient carefully. For example, is the position of the antagonistic elements a cause or a consequence? The moment the dental elements come into contact, they end their active movement. But in case of parafunction, what happens? It happens that the rush is activated again by coronally movement of the tooth and of the periodontium. We see the case of altered passive eruption, in which is evident that the dental elements are absolutely healthy, while periodontal tissues are very thick and slightly scalloped. And we will have to understand what happened biologically to avoid a therapeutic error, such as a gingivectomy, for example, obviously to be avoided in cases like this one. So, talking up the problems we have just analyzed, in which of these are we called into question? I invite you to think differently. Why do we have to deal with these cases? These are not pathological conditions. They are not conditions related to infectious or inflammatory phenomena, but they are alterations of physiological mechanism of our patients. We are called to treat these cases because the aesthetic request from the patient is increasingly predominant. Furthermore, we are called into question because the goal of this treatment is represented by teeth, and we are dentists. As therapists, there is actually a condition that we should know and treat because it represents a risk factor for periodontitis. It's a subcategory of the altered passive eruption, in which a pseudo pocket is formed determining the condition for the development of the pathology in the predisposed subject. We will see it later. Well, as we understand, diagnosis is essential, and DSS, Digital Smile System Protocol, is the key because it can help us to diagnose, especially when aesthetics are the subject of the clinical request. And I show you a clinical case in which the smile is apparently harmonious. But I show you a different perspective. What have we done? In the previous slide, we have inserted a mock-up, while in this slide, the mock-up appears separate. Look at how much dental tissue our patient is missing. It's truly amazing. Let's see the condition at the baseline. The patient had a recurring vice that continually biting her nails by removing quantities of dental elements and causing disharmony in the gingival parabole, especially those of the two central. I believe that the key is to make a correct diagnosis, and although the diagnosis is of an altered active eruption, DSS incredibly helped me choosing the most appropriate therapy, that is the correct therapy that also meets the patient's needs. You can see here, okay, the full mock-up, the mock-up in the mouth. Because it helped me to make a mock-up very quickly, even chairside, I can decide to leave the mock-up intraorally to check if the function is correct, and that you can proceed to lengthen the elements without performing surgery, creating reversible treatment for such a young patient. We thus enter the world of digital dentistry, and thanks to a simple but rigorous photographic protocol, we can preview the new smile. Just 2 photographs. And one intraoral scan and one impression to be digitalized are required. In this way, with the bidimensional and three-dimensional workflow, we can perform a diagnostic workup and print it immediately. On the right, you can observe the condition at the baseline, and on the left, the new condition. In this way, it's very clear the extent, the quantity of the dental wear, and the nature of our treatment. Therapy is therefore guided by diagnosis. This is appropriate therapy, conservative, consistent, and without ever having used a drop of anesthetic. Here are the prepared elements. In practice, a finishing line was simply defined, really mini-invasive preparation. We already know the result because thanks to the mock-up, we have tested and appreciated it. These are the final restoration. These are the adhesive procedure. And these are the images following the cementation. And the rediscovered harmony on his smile. The satisfaction of the patient who returns to dental office in a different light, smiling with her eyes. So let's analyze the entire workflow. I made a correct diagnosis thanks to the help of the new technologies, in particular the DSS, a correct preview thanks to the mock-up and an appropriate therapy, appropriate because it has fully achieved patient satisfaction in compliance with the mini-invasiveness without considering any surgical procedure. Without surgery. Well, let's now deal with more complex cases in which the presence of periodontal disharmonies is evident. The correct diagnosis is always the starting point. Therefore, to understand if the problem is of a dental nature, that is of an altered eruption, and what type. For example, in this case, you have different conditions. Altered and passive eruption is normal in the same mouth, in the same system. We always look at patient at 360 degrees, not only by lifting the lid to get a more complete picture and better define the target of the treatment. What is the rationale for establishing the best therapeutic sequence? It's always biology that guides us. And here I know everyone will think, you don't want to talk about the usual biological width? Yes, but with some important news. We cannot talk about periodontology without mentioning Gargiulo from 61 at least once in my lecture. But the question I ask myself is the division of the biological width in 3 compartments is still relevant? Is it correct to consider the sulcus as an active part of the biological width? Is it correct to consider the epithelial attachment as a real attachment? Histologically, it's a junctional epithelium composed of a connective that support it and push it towards the dental enamel, because the junctional epithelium is positioned above the CEJ, and the contact with a smooth and clean surface determines the expression of hemidesmosome from epithelial cells. So this is the epithelial adhesion and not attachment. The attachment is what is underneath the connective one, in which there is a structural integration of fibers in the root cement. Therefore, an interpenetration of fibers occurs between the root cements and the supercristally connective tissue. Unlike the connective tissue attachment, the junctional epithelium is adherent to dental element, not attached. Is it therefore correct to call it epithelial attachment? I think not. Let's begin to make the first distinction. The sulcus does not belong to the biological width. I'm not crazy. I know that there are rules to be respected, that the magic number is 3, and that a distance must be kept between the prosthetic margin and the bone crest. But I also know that the scientific studies are very dated. And if on the one hand, biology cannot be changed, on the other one, the key to understanding biology can be changed thanks to studies conducted in recent years. Therefore, I ask myself, the distance is the same for all people? How can I measure it? And can I preserve its values over time? But really, what is biological weight? The latest classification of periodontal disease introduced a new definition, supracrestal attachment. The terms biologic weight should be replaced by supracrestal attachment. Hence, the biological width to date is defined as the compartment involving the supracrestal tissues attached to the dental roots. The junctional epithelium is instead part of the supracrestal tissues that don't attach to the roots. It's, so to speak, a temporary hinged entity which in inflammatory condition determine the detachment of the epithelium from the enamel surface. The supracrestal connective attachment, on the other hand, cannot fail to exist. It's an entity that must necessarily be present. Well, let's go ahead and define another entity. We will take this concept later to introduce it in therapy, the phenotype. We are increasingly talking about phenotype and less about biotype. Probing is always the key. Why do we define 1 millimeter as the limit value? Because we know that the radius of action of the bacterial plaque is about 1.2 millimeter. And if we have marginal tissue thinner than these sites, we will have a recession because the inflammation will involve all the connective tissue between the 2 layers of epithelium, the junctional and the keratinized one. If the marginal tissues are thicker, we are faced with a thick phenotyle. But phenotypic expression is aimed in particular toward hard tissue, the bone. And this expression guides the extent of bone resection. How much bone must we remove in respect of the supracrystal attachment? 3 millimeters for everyone? No. This way was the concept we believed in when we considered the value of biological weight as a standard. Today, we have an individual parameter, and then also the extent of bone resection based on the phenotype. This is a concept not to be forgotten. So that is the compartment, the supracrystal attachment. And these are the value that we have to respect when we perform a resection surgery. In any case, the fundamental procedure remains this: the probing to analyze the target of our therapy. That is, which tissue we are treating. In this case, two decidedly different phenotypes, for example. But here we are in an era when I had no digital technology, but the concept were the same. My periodontal surgery did not vary. It can be seen, however, that I was a little empirical in the incision. Not that I was wrong. I made my measurement, my working, but I cannot ignore the important role that a previewing digital tool can have. Observe, for example, how I calculated the limit I wanted to achieve with my surgery, drawing markers in the in the exposure of the smile, and drawing the related incision freehand. Excuse me. Like a pencil, you can design your incision. We have not new technology, so we cannot preview the new parables. And now, but let's see how our approach has evolved. If we have a clear understanding of biology, we can give proper weight to aesthetics with a certainty satisfying the target. Let's look at this case report. So sorry. We have an evidence asymmetry. Between the two after the active eruption, while the left canine show a recession. Two very different surgical treatments. As always, the digital smile comes into play with the model that derives from the intraoral scan. It's performed the matching file with the smile photograph. All files are merged, and then diagnostic works out. In this case, we have created an indirect mockup that is printed in the laboratory. Obviously, being superimposed on its dental elements, it will be increased in size. If the canine was extruded, it will now be even longer. But what matters are the parables to redefine the new tissue frame and to redefine the global harmony. Such a mockup has an incredible diagnostic value and an important communication tool. For example, for this patient, it's important to have an indirect mockup in the first visit. This mockup will be the guide for a template that will allow us to perform the next periodontal surgery. Thanks to the relative fenestrations, this template will greatly increase the precision of our incision. We have also created a second template that will allow us to guide the extent of the bone section, because it represents the future margin of the prosthetic restorations. We therefore have these two templates, the result of the same digital project. I show you the short video of the intervention. This is the template. We can appreciate how precise is the fit of each prototype. From the template to the mockup. The presence of templates is so important because it allows you to quantify the extent of the tissue remodeling. For example, you have here area greater where you have to redefine your parable. And you can use your blade like a pencil. On the lateral incisor, for example, you don't need to cut a lot of tissue. You can bevel your blade thanks to the template. And you can redefine your new emergency profile. Well, at this point, we must put our biological knowledge into play. The preservation of the papillae, where possible, the partial thickness flap at the base of the papilla. We lift the flap and we dedicated ourselves to restorative surgery. For example, here. Oh, I'm so sorry. But it's not a problem. The template is your guide. You can perform a perfect periodontal surgery, always guided by your digital project. Here we are at the healing. You can recognize microsuture. Here it is. And it's amazing that there is a perfect correspondence between the initial project, the pre-visualization, and the prosthetic restoration. I always say that if we can see it, we can achieve it. The soft tissue response, the answer will be positive if the periodontium and its biology are respected. Is all this enough? It's not. A passage is missing. This classification is very important. It is the one currently accepted in relation to the altered eruption. We have two classes, type 1 and type 2. The difference is made by the keratinized gingiva. If the bone crest is positioned coronally to the mucogingival junction, is the type 1. If apical, the type 2. Distinction is essential for positioning the primary incision. In type 2, for example, the incision must be much less scalloped and beveled than in type 1. There is a further subdivision within each class, type A and type B, and it depends on the context, on the extent of the connective tissue. In type B, the supracrestal tissue is very minimal. I like the subcategory A. Knowing perfectly the position of the bone crest in relation to CJ is really important to perform correct periodontal surgery, respecting the patient's anatomy and biology. There are numerous two-dimensional evaluation methods supported by literature to understand the real distance between bone crest and the gingival margin. For example, this one. And there are other three-dimensional ones. Here my interest has gone a little deeper. Several studies try to identify the individual biological width of the patient at CBCT. However, I share the opinion of many clinicians that it is not always possible to identify at the cone beam the cortical tissue if it's thin or not perfectly mineralized. In cases where it's necessary to do a cone beam, we can make this kind of protocol. We can create a virtual patient also in periodontology. We can match STL and icon files to identify very precisely where the gingival margin is positioned with respect to the bone crest. And not only, we can add more information thanks to DSS, Digital Smile System. Let's look at this patient. He's a patient I show directly on the day of the surgery. Thanks to the digital technology, we can make the diagnosis and a remote treatment plan. The patient asks to improve the harmony of the smile, especially the right side. Therefore, we carry out the DSS project, as we can see now, and superimpose the DACON file on the digital project. Thanks to the superposition of the DSS project, we can perfectly analyze the position of the future gingival margin from the bone crest. Here we have the diagnostic workshop, the digital workshop. Here the ways in which is made at CAD. If you did correct photographs, you don't need no more time for having a correct matching file between the two files. You can have a correct superposition between PNG file and STL file. So you can see perfectly the difference between the new emergence profile and the anatomy of the patient. And finally, you can print the model, the starting condition, and the arrival condition. Once the new periodontal parameters have been identified, we can print the surgical template, which always derives from the diagnostic project, always. This template presents additional information because, unlike the previous case in which two surgical templates are shown, I have introduced an evolution here. If the blue part corresponds to the diagnostic workshop, the internal part represents the incision line. And if we have measured the patient's biological width, we can directly report it on the template and let our service be guided in the ostectomy. So with a single tool, we report all the parameters for a correct surgery. And this frame corresponds precisely to the supracrystal attachment, that is, to the width of the patient, the supracrystal attachment. So, with a small video, I show you this innovative approach to treatment, to periodontal treatment. So look at how important the probes are, even 5 millimeters. I can go faster on the video. Okay, you can see the feet exactly should have. And you can use your template like a guide for your blade. Right now. Okay, you can remove your template. You can see your incision. While improving our incision, respect papilla, always. We have to respect our papilla. We have a partial thickness flap in papilla areas, and then full thickness flap for uncovering the bone. Okay, like this one. Okay, cutting all the fibers. Okay, look on 1.2, how the superficial attachment share is evident. While on 1.1, I can perform ostectomy with a dedicated rotating instrument. I can show you now the bar. Okay, look at here. You can see perfectly, for example, there, the superficial attachment. Well, thanks to the guide, you can mark exactly the new emergence profile. This is the dedicated rotative instrument. Instrument does not remove the attachment fiber on the top. Okay, it's so important. And on the other hand, it's very important to carry out correct osteoplasty in the interproximal sites where the cause of the problem often lies, the bone balconies. Finally, at the end of this osteoplasty, okay, you can appreciate the new profile, the new bone profile. So the control the bone remodeling, and then you can put your sutures. And thanks to the partial thickness detachment of the papilla, it's so easy. This is always the same suture, a continuous one. Well,
Hi. I think the video has stopped because of the internet.
So,
if you can go on with your presentation without the video.
Problem. I am my video. It's so important. First of all, the target. For example, perfectly identifying the superficial attachment, and then the incision. For it to be correct, we must have a clear understanding of the classification of the altered eruption. And finally, the ostectomy to be performed on the basis of the phenotype. Let's remember 3.5 and 4 millimeters for the thick one, while 3.5 millimeters for the thin one. At this point, diagnosis and therapy are perfectly integrated in this workflow. Two different moments of the same cycle. Digital smile system is an important diagnostic aid, while the therapy will be biologically guided. So, what are the key factors? Digital smile system is the key, because the diagnosis is always essential and unique, and the therapy is consistent with the diagnosis. Don't forget that the digital is not a solution, but is a tool which helps you to simplify and control many operative phases. Diagnosis come first of all, then associating a correct pre-visualization with the knowledge of biology gives a synergistic effect to our approach to choose the most appropriate therapy that is the correct therapy for that patient. This is my message. Thanks for the invitation. Thanks ESCD and Just Digital in the name of Veronica especially. Thanks the audience for your kind attention. I'm so sorry for my voice, but I have a problem today. And I think that I was not so boring in my lecture. Thank you very much for the audience.
Thank you for accepting our invitation. And, I would like to first address some questions about the presentation. First of all, it's what is your opinion about piezo surgery and why you don't using any piezo for remodeling of bone, but okay, you use the diamond burr?
Yeah, I love my instrument, but if I have to talk about ultrasonic instrument, I prefer to use subsonic instrument. I think that the subsonic instrument, for example, like Sonic Flex, let you to control in a better way all the movements of your instruments. In that case, for example, I need a special rotative instrument for having just the cut on the tip of the instrument. And in the other side, we have a great ball, round diamond ball, okay, for perform the correct osteoplasty. I can control in a better way this one, but it's not a problem if you want to use it too. If you prefer to use the piezosurgical instrument, it's not a problem. I like so much this kind of technique.
So, as I understood from your presentation, there is a shift of concept from biotype to phenotype.
Yeah.
And you're creating your own gingival margin or the new biological width in according to the distance between the crown, the future crown, and the bone crest. So you're moving the bone crest upwards, away from the crown margin, and it needs to be at least 3 millimeter distance. What happens if you have a very thin biotype of gum? How long do you wait after this osteotomy to heal and to start with the prosthodontics?
Okay, thank you very much for the question. First of all, you have to recognize exactly which kind of phenotype your present show. It's so important to talk about phenotype and not biotype, because for a lot of years we are convinced that the biotype is genetically given, exactly. Okay, but exactly now the more recent studies show that phenotype is genetically given. The phenotype for phenotype we have to consider the hard tissue and not only the soft tissue, the hard tissue and the bone, for example, that are surrounding the teeth. For example, in the altered eruption, the problem is always in the bone, in the interproximal areas. And if you don't recognize this kind of phenotype, and you have a lot of radiographic methods for having a diagnosis, or you can also probe, okay, exactly until the bone crest your patient. If you cannot recognize this kind of condition, you can have a so big problem to have a gingivectomy, and you can leave there your supracrestal attachment. And for example, if you perform your prosthetic preparation of the teeth and you put your finishing line in such a position, but you have not respected the correct distance between the future margin and the bone crest, you will have a so big problem in the future, because the new biological weights always is originated in that position, so near your prosthetic margin, and you will have an inflammation forever. Okay. So you have to recognize the phenotype. If you have a thin phenotype, you cannot cut your bone crest for more than 2.5 millimeters. Okay. That is the last recommendation of our academy, the European Federation of Periodontology. So 2.5, okay? And for example, in that kind of case, in my surgery, before I have to perform my incision, because the incision is guided by the prosthetic project, by the aesthetic recast of the patient. So I can put my incision, and if I don't have keratinized tissue, enough keratinized tissue, for example, in type 2 of the altered eruption, I cannot have a paramargin incision. Yeah.
One more additional question to this is, do you do bone remodeling of interdental spaces so that the bone support don't appear too much in the posterior?
Okay. Yeah, in the interdental spaces, you have not removed if your target is to achieve the correct, the new aesthetic for the patient. And for example, in all that cases of the new remodeling of the anterior area, we cannot want to remove the basis of the papilla. We preserve the papilla, we preserve the blood support, and then we reposition the flap in that position. And always you have to consider perfectly, first of all, the phenotype. If you have, for example, in the last video on the elements on the lateral incisor, I had just a correct distance between my future position of the margin, of the prosthetic margin, and the bone crest. So I have not touched the bone crest, just remove my gingiva. And I have to preserve the superficial attachment exactly in that position, that in a thick phenotype, you have to consider 1 millimeter, 1.5 millimeter more. So you can have an attachment made of fibers 3.5 and also 4 millimeters, and you have to respect it.
We have one more question. What kind of tooth?
That's where
you're hearing me? Because there's a, I don't hear you. Do you
what kind of
tooth preparation do you prefer in these cases, and where do you place the margin of the preparation?
Okay, well,
So it's paragingival, as I understood.
Yeah. Normally, for example, if I want to realize veneers,
Yes.
my kind of operation depends of the material that I want to use. I have to choose the correct preparation. For example, if I have to use a disilicate, that is different if I want to use a zirconia, and always it is different is if I want to use a metal porcelain. And for example, in veneer, I would like to have a little chamfer, so little horizontal preparation to have a correct and always so finishing line, always that help me to correct positioning my restoration. And when I stay with the rubber jam, it's so difficult to have the correct position if you don't have a finish line. You can have some trick for the preparation, for example, for the preparation of the interproximal spaces, but I prefer to have a correct but so small line in all the, in all the, exactly. And
so what is your favorite material for the prosthetic cases like you show us? They're mostly veneers. What do you prefer?
I like so much if I for sure depends on the color of the teeth, but if I can choose my prefer, I would like to use the not the silicate, but the most delicate restoration. Feldspathic. Thank you very much for the aid.
Your ceramic.
Feldspathic, yeah. If I have enamel, I always prefer feldspathic ceramic. If I need to have strong restoration, I have to put I have to use a disilicate in the anterior part of my mouth, and I prefer zirconia for the posterior part. But it depends a lot of factor. For example, the occlusion. For example, in the previous case, for example, the strong wear of the incisal edge, and there I choose a disilicate, but not with a CAD procedure. I don't like mill ceramic. I prefer presso fused ceramic. So exactly.
Yeah, I'm so happy that you were with us today. And please, if you would like to put in the chat box your email address, if some of our participants want to ask anything else. And just to let you know that all our Italian friends are helping us today for free. So this is their solidarity for the Macedonian dentists to learn more, to learn better, to give extra services to our patients. And let's hope that we will meet again in live in Macedonia or in Italy or some other event when the borders are open.
I think to meet you and all my colleagues as soon as possible. Now in Italy, the situation is not so easy, and I think for all over the world it's so difficult to move ourselves. But I hope for this summer to going abroad and reach you. Thank you very much.
You're welcome. You're welcome. So